Welcome everyone to Alan Hu Foundation Mental Health Lecture Series. I'm Qi-Chun Hu, co-founder of Alan Hu Foundation and host for your webinar. Today, Dr. Nolan Williams will present Interventional Psychiatry, The Time is Now, and sorry about the title change. I believe there's another title change, but they are the same content, I believe. We'd like to thank Three Valleys Community Foundation for funding this webinar. We'd also like to thank Mental Health Association for Chinese Communities for providing simultaneous Chinese interpretation. And thank you to Ida Xiao for Chinese interpretation. Alan Hu Foundation's mission is to promote mental health, raise awareness, and remove stigma surrounding psychiatric disorders, and support fundamental research for cures. Please consider making a gift to Alan Hu Foundation by using the donation link in the chat box. Thank you for supporting our programs. And today, it is our great honor and privilege to introduce Dr. Nolan Williams. Dr. Williams is a psychiatrist, neurologist, and associate professor at the Stanford University Department of Psychiatry and Behavioral Sciences. He is the founder and director of the Stanford Brain Stimulation Lab. He has an extensive background in neuropsychiatry and is triple board certified in general neurology, general psychiatry, and behavioral neurology and neuropsychiatry. He has a specific training and clinical expertise in developing and implementing novel therapeutics, including devices and novel compounds for central nervous system illnesses. Themes of his work include examining the use of spaced learning theory and application of neuromodulation techniques, development and mechanistic understanding of rapid-acting antidepressant therapies, and identify objective biomarkers that predict responses to neuromodulation treatments. In this talk, Dr. Williams will explain Stanford's Accelerated Intelligent Neuromodulation Therapy, also known as SINT, a new form of individualized neurostimulation for treatment-resistant depression. In a double-blinded, randomized control trial, 79% of participants receiving SINT treatment achieved remission from depression following the 5-day treatment protocol compared to just 13% in the sham group. This webinar is being recorded. The recordings will be available on the Alan Hu Foundation website and Alan Hu Foundation YouTube channel in about 2 weeks. Please subscribe to Alan Hu Foundation YouTube channel. And following the presentation, there will be a Q&A session. Please use the Zoom Q&A function to submit your questions. The question is for educational purposes only. It is not intended for medical diagnosis. If you have any persistent symptoms, please seek professional help. With that, I'm turning to Dr. Williams. Welcome, Dr. Williams.
Thanks for having me. Let me share these slides. Allow more. Okay. Great. Okay.
Yes, I can see it.
Here's the neuromodulation approach that we developed and some biological measurements that we're finding could be useful in prediction of that effect. So, I'll start with this. You all know that if you start having chest pain, wherever you're at, in your house, in the grocery store, whatever it is, there's certain things that people can do in that space. They can check your pulse. Maybe somebody has aspirin or something they can give you. But really what needs to happen next is the ambulance needs to be called. People need to be brought to the emergency room where they're brought into higher levels of acuity, where there are more tests and more treatments. And maybe you end up in the ICU where there are even more tests and more treatments. And that's how most of medicine works. The problem in psychiatry is that if you're seeing your psychiatrist saying that you want to end your life, you end up being in a scenario where they too call the authorities, but instead of the ambulance coming to pick you up, you end up in the back of a squad car, at least in the state of California, And you do end up in the emergency room in these cases, but you are there sometimes against your will and sometimes in a hallway bed for an extended period of time, sometimes a week straight, waiting on a psychiatric bed. And when you get up to the psych unit, what you realize after the first time one is admitted into a situation like this is that this available to you is a outpatient, not in a hospital, not under, under a setting. And people have this dramatic realization that they've got to the pinnacle kind of level of acuity of care within psychiatric um, care continuum. And it's no surprise that the suicide risk triples after discharge from the hospital. So, we became very interested in this problem because depression's a huge problem. Oral antidepressants don't affect suicidality. Most of the treatments we have are quite slow, and suicidality peaks at 3 times lifetime risk right after discharge, as I said earlier. And the average length of stay in the United States is about 7.5 days, and about 500,000 people a year 10 years ago were hospitalized for suicidal depression. It's probably more like 250,000, 750,000 now. So TMS has been around for some time. It's a technology that basically uses electromagnets to induce currents within electrically conducting substances, and so in this case, brain tissue. And the idea really is to send a signal into the brain that the brain will react to. And so if you send a single pulse into the brain, it won't do anything to change the brain. But if you, like Morse code with a telegraph, can send a signal from the sender, the device, into the receiver, the brain, that speaks the language of the brain, you're able to change the brain's kind of native activity levels. And so that the idea of TMS was developed in the mid-80s. The kind of language was starting to get deciphered in its kind of very kind of proto forms in the mid-90s. And with that early finding, folks were able to use those stimulation approaches to change targeted areas outside of motor cortex in areas involved in mood regulation. So the original TMS approach was approved to be administered over the course of 6 weeks, and doesn't really solve the acuity problem. And this was done primarily because it was a concern about risk, right? Inducing seizures or other risk, which, we found later to not really be an issue. But in the mid-90s, this is what people were really worried about. And so they did this very slowly, very carefully. And they also did it using skull-based measurements. And surprisingly, a third of people will remit with that. Another third will be responders to that, meaning they have a 50% reduction in symptoms. The second generation stimulation approaches really approaches that more closely mimic the rhythms of the brain, the actual natural memory rhythms of the brain. And these are really sending information into the brain that aligns with the way memories are stored. And the rationale there is really what you're trying to do is just simply send a memory signal to tell this, in the case of depression, tell this brain region that's underactive to kind of turn on and remember to stay on more. And the view is that things like cognitive behavioral therapy, you know, other forms of psychotherapy, motivational sorts of things, really doing the same sorts of thing. It's just turning up the control system. And we do that by sending these patterns, these, in this case, 50 hertz bursts every fifth of a second for 2 seconds. And that tells the brain to turn on, at kind of double the amount that it was before. So if depression is an underactivity problem, it really allows for you to turn that system on, and it does it very cleanly. And outside of this, somewhere between, at least for our technology, being between theoretical and like 1 in 30,000 person seizure risk, there's not really much in the way of other risks because you're right there at the actual network level, turning that system back on. And so there was a non-inferiority trial with conventional TMS that was done back in the in completed in 2018, and this led to an FDA clearance for Theta-Burst. And so what it did is it shortened the time in chair to 3 minutes, but did not change the schedule, right? And so what we saw as one of the problems of this is that the actual position of the coil really wasn't with the older technologies consistent within the brain. And so the way that people were having to do it in the 90s, because of the nature of MRI technology and how hard it would have been to try to get MRI even 10 or 15 years ago in these circumstances, they were really using ruler-based measurements that allowed for you to get kind of average positions within the dorsolateral prefrontal cortex, this area that's underactive in depression, but didn't really allow you to get so specific that you were able to hit this network node in the same way every single time, right? And so we had the view, 10 years ago when we started this work, that it was really a problem of lack of personalization. So, back to the situation I described earlier about, folks not having, kind of an emergency treatment within the context of an inpatient admission generally, so we started at this kind of base case set of questions around, can we use modern day neuroscience to inform us on how to do this the right way? We're trying to turn this brain system back on that's underactive in depression. How do we do that? And so we we basically took the stance that we needed to stimulate, as with as many pulses and with the correct intensity that it would take to produce the largest amount of change in brain excitability. Interestingly, that's not by turning up the dial on the intensity. The brain seems to have this sweet spot of intensity and pulse dose that is quite specific. And if you keep going up on the intensity, you actually start to lose the effects. So 90% at 1800 pulses. And so we've continued to use that approach. This is the application of this in a Taiwanese study where they're able to show that this works and separates from sham. And then once you know kind of the units, so the pattern, the intensity, the pulse dose, then the next thing that's important is to figure out the kind of the timing, the spacing of it, the cadence of it. And we've known for some time, based off of space learning theory, that you can't, kind of load a bunch of information into the brain without breaks. The brain needs breaks in order to produce proteins to strengthen dendritic spines and make longer term effects. And so there's been basic science experiments showing this, like this one, showing you need about an hour to hour and a half in between each application of stimulation. And this is giving the same theta burst stimulation where you're actually increasing dendritic spines and enlarging the connections. And by the way, it looks like this is how psychedelics work too. This is how ketamine works. This is how psilocybin works. These same kind of findings of increasing dendritic spines. And so it also works in learning experiments. So if you take somebody and you show them something and you wait about an hour and show it to them again, it's much more powerful than if you show it to them twice in a row in the same time period. And we kind of intuitively know this, like people know this. If you've ever studied for hard tests in college or grad school or med school, what you learn is that you can't make a single note card and look at it 50 times and then stop. You need to make 60 note cards and you need to look at each one of them for a minute, and then you get back to the first note card an hour later. That's actually like, humans can actually intuit the space learning phenomenon because they really need time to re-experience it. And we know if you do stimulation, you can recapitulate this finding. If you wait 15 minutes, you really get no change in cortical excitability. You got to wait longer to see that. And so that's the rearrangement in time that we worked on and kind of worked on the engineering around. The second one is the dose. And so what we found is that if you give TMS, the original early studies were really kind of zoomed in to this concern around how much dose would be safe. What we've learned is that this is incredibly safe, and that giving more dose doesn't, in the sense of like a daily dose or with time in between, doesn't really increase any sort of risk. And so subsequent trials said, okay, let's just keep treating people. And this one treated people out to 16 weeks. And what you find is that you really plateau the effect out at a much later stage. And so 61% of people that didn't respond to the original trial actually then became responders to this. The third thing that we became focused on is this rearrangement in space, which I talked about a minute ago. This kind of standard skull spot trigonometry stuff isn't going to cut it. Is there a way to kind of see within a named brain region the right spot? And so the first question was, what's the cortical region that you're going to go into? It became clear that the dorsolateral prefrontal we really had the most data back in 2015 when we started thinking about this. And so, there are these conceptual models that mood regulation really is dorsolateral, suppressing this part of the cingulate called the subgenual anterior cingulate. That's really how effective mood regulation works and perceived control works. You can disrupt that and you get dysregulated mood. And in fact, strokes that cause depression, they all have functional connections to these networks, right? And so we know that if you disrupt these networks, you induce a depression, even in the structural sense. And really what TMS is doing is just re-regulating this network. And so, we became convinced that the way to deal with this is to use network-based localization techniques. And so trying to find an access point and trying to find a downstream network in each person. In this case, it's the dorsolateral to the subgenual, as I talked about earlier. And the reason for that is because there's been a whole host of retrospective trials and now a positive, yet to be published prospective trial showing very convincingly that if you're right over top of this kind of ideal brain spot, that the TMS works a lot better, right? So it's the most replicated imaging finding in psychiatry. So we do this at the prospective level. Everybody gets a target scan where we look at this kind of dorsolateral region, we look at the subgenual region, we try to find this ideal spot for them. And the reason for this is we're trying to increase their efficacy and also reduce, off-target effects. If people have side effects from this because it's too close to other brain regions, we want it to really be the safest, most effective spot for them. And so we find this kind of ideal spot, and then we stimulate over that ideal spot. And so what we're trying to do is in each person find this network node and then apply the coil into that network node and really modulate that system as effectively as we can. And so that's really the kind of goal there, is to kind of zoom into that brain network and really modulate that system. So this again, kind of right target spot, right stimulation approach for each person. And what we're doing, again, from a dosage standpoint, I'm just going to reiterate what I said earlier, is we're using memory system signals. So this 50 hertz bursts every fifth of a second. This is really how your hippocampus processes memories. And we're just playing that information back into the brain. In this case, to tell the brain to turn on, remember, turn on, stay on, remember to stay on. And you may ask, like, well, why do that, right? Well, it's because the memory system, especially in early childhood trauma, learns the opposite, right? That really what happens and why people with early life trauma are so treatment resistant is because they process that information in the opposite direction. And so we're trying to change the flow of information, and we're going to use this kind of hippocampal rhythm every hour, like I said, because of the space learning theory phenomenon. We're trying to stimulate in a way that really recapitulates the learning processes. And we're trying to teach the brain to learn to keep the system back online. And so again, we're using an entire course of stimulation, and we're reorganizing it in time to be able to give it um, in a single day. And that's how we're able to give this in such a way to where people actually can be better in one day, be better in 2-3 days. It's really quite dramatic. So that's the idea. And so we give 5x that dose to try to get people out of it. And yeah, this is just another way of looking at that information. Another way. So reorganization, time, space, and dose. As I described earlier, this is our first trial that led to the clearance, FDA clearance, the Medicare reimbursement. So 50% of these people were unemployed due to depression. Their average length of illness was 9 years in the current episode. So these are really, really quite ill folks, 25 years, lifetime, 5 ± 2 med failures, a MADRS in the low to mid 30s, so quite severe people, response rates on the bottom, Cohen's d effect size is all above 1, really dramatic differences. And importantly, a few people had, a headache after that's Tylenol responsive, but no seizures, no side effects. Cognitive scores improved in people, unlike things like ECT where you see detriments. All right, so we'll talk a little bit about this biomarker we've been developing. That's Anish Mitra. So you can actually see patterns within the fluctuations of the electrical activity is reflected by blood changes in the brain that in normal mood, that dorsolateral region actually temporally precedes the cingulate region. It clamps down, it controls it, as I described earlier. And when you successfully treat somebody with SAINT, you can actually flip the organization of those brain regions such that that happens, that the dorsolateral actually again is dominant over the cingulate. On the pre-treatment, um, the contrast between the depression scans and the healthy control scans show you that in depressed people, before they were treated, the cingulate really is prior to the dorsolateral in time. The cingulate really may be driving the dorsolateral effects, and that if you look at really highly responsive individuals and you look at non-responders, the difference between the two looks like the difference between the healthy controls and the depressed patients in the previous panel, that really people that are highly responsive to SANE actually end up having this flip, this cingulate dominance initially, and then they're the ones that go on to flip their networks in the right direction. The people that have no response look like normal healthy controls, and their brain really doesn't change after. And so we have new data now that we just unblinded, people, about 48 people in this trial. Folks, primary outcome was remission at 4 weeks. This is our demographic table. So, people in kind of moderate to high severity depression, several years duration in many cases. And what we found is something similar to the last trials, that about 70+% of people in the active group remitted compared to 20-ish% in the sham group. And that held at the 4-week mark for remission, both in the ITT and per protocol was closer to 60%. Responder status was 54% and 60% per protocol. And pretty dramatic drop in symptomatology across the board. So this is my group, and all of the funding that we've received, and happy to take any questions from you all.
All right. Thank you, Dr. Williams, for introducing such a nice treatment method and very promising, amazing result with us. Okay, so a lot of questions are regarding can SAN treat other mood disorders such as OCD, ADHD, PTSD, bipolar, or autism?
Yeah, so we have data for OC, I didn't show it, but for OCD, bipolar, and we've had cases of PTSD. We also have a trial that we're going to start up for postpartum depression soon. So it really is, a broad technology, not just a single disorder.
Okay. How about other neurological disorders or a brain disorders such as Parkinson's or dystonia or dysautonomia?
Yeah, no, it's a great question. And so for the Parkinson's, we've looked at Parkinson's related depression and we've had cases where folks have gotten better there. I've heard of cases of people getting TMS that have had dysautonomia and they've improved. We have not run any trials on that. So,
Mm. Are there any side effects of a SAN treatment?
um, there's no side effects that we know of beyond the headache. We've seen headache in a small percentage of people. A lot of it's Tylenol responsive. We've never seen a seizure, knock on wood. I don't know if you can have a seizure with this if you're your submotor threshold. That's one of the kind of thoughts that we have about this is you probably
Hmm.
have to be supramotor threshold to have a risk. And yeah, I think that's really it. It's just really headache.
Okay. And what is the youngest age group of people can benefit from SANT? Can pediatric patient use SANT or adolescent?
Yeah, it's a great question. So we've treated adolescents successfully. I'm not aware of anybody below 10, for instance, that's gotten it, although like I don't know everything that's going on in the wild now, but teenagers have definitely gotten it, have benefited greatly. And it doesn't seem like there's much in the way of risk there. So
Okay. What is the difference between SANT and ECT?
oh, yeah, big differences. So ECT, the goal is to have a seizure. It's thought of as a therapeutic seizure. The goal of all TMS is to not have a seizure. So in that
Mm,
way, they're completely different, and the goals are completely different. Completely opposite, right? The goal of ECT, you need anesthesia for ECT. You don't need anesthesia for TMS.
right.
Really what TMS is doing is trying to, in a non-seizure kind of way, and like just a modulation of brain activity way, we're just trying to change brain network activity, and we're trying to do it with the person awake and, largely, I mean, I always tell people that all medical procedures that are good are always boring. The more boring it is, the better it is for the patient. And the view there is that a boring medical procedure means the patient's not nervous, the patient's not worried about it. They're thinking about other things. There's not really much pain. There's not really much side effects associated with it, and they're doing something else. And that's really what sane is. I think that's what TMS can be even more generally, is it's a boring procedure, which from my standpoint is a great thing, right? Because that means that the patient, is fine, and they're like, at their base level of kind of thinking about things.
Okay. Is effectiveness different for different patient age groups?
Um, so this has been a question that we've been working on, and so far we see no differences in age groups. We published a geriatric um, kind of cohort in the AJP that looks very similar. We're going to put together a younger case series in teenagers. It all looks very similar, and generally TMS, across the board, age is not really a factor. So
Okay. What is the success rate of assent when treatment-resistant depression doesn't respond to conventional TMS, ECT, esketamine, etc.?
Yeah, so we've treated people that have failed or responded to ketamine, esketamine. This works. We've treated people who failed normal TMS. This can work. We've treated people that have failed even electroconvulsive therapy, and this has worked.
Okay, that's great. Um, is SENT a one-time or recurring treatment for depression?
It's a recurring treatment in most people. And so, the kind of cadence of that is very different across people. It can be as I've had patients who've gone 5, 6, 7 years without needing any more. We've had patients who are just really, really refractory that need kind of ongoing scheduled maintenance treatments. The good thing is there's not an accumulation of risk and there's not an accumulation of side effects. And so, if anything, we see a kind of a improvement of efficacy over time. And so that to us signals that there's not really an issue there. So
Okay. And how long does the treatment result endure? We know that RTMS result can fade in time.
yeah, and so it's longer than conventional RTMS if you adjust for the treatment resistance level. So it's just different in different people. What I can tell you is if you do maintenance treatment on people, you can maintain them indefinitely.
Okay. Um, Another category is, can this treatment be used on people with autistic and genetic disorder?
So we've treated people with autism and depression, and the depression's gotten better in those autistic individuals. Yeah. Genetic disorders is a little hard to know as a broad category. I mean, certainly some of them, I think it's just a question of what it is exactly.
Do they, for the autistic spectrum individuals, do they respond differently?
We haven't seen that,
Mhm.
we haven't seen that yet. So,
Okay. Um, can consent be used to prevent depression?
well, we have this maintenance protocol that tracks people who've been successfully treated and then triggers retreatment before they relapse. So in that way, yes. Now, could you do it before anybody's ever had a depressive episode? That's a really open question and an important one.
Hmm. How long does the pre-screening MRI take?
Like in a half an hour.
Okay. Can the research data of SAND be used to better understand the mechanism of the brain?
Yeah, yeah, that's one of the big things that we've been working on. So that new trial data that I just showed, we scan people every day to try to
Mhm.
understand that very question. Yeah.
It's by scanning different area of the brain with a different brain circuitry to understand this
It's the
a
whole
different.
brain. It's the whole brain, but it
Mhm.
but it definitely, you can look at different networks that would change. I think there's some questions around getting this. So it's commercially available. It's been approved. It's been cleared by the FDA since 2022 and
Mhm.
um and paid for by Medicare and by Blue Cross Blue Shield now.
Oh, that's wonderful. Um, is is this available other places in the within the United States or
Yeah.
even abroad?
All over the country.
Okay, great. Can SAM be combined with other treatment methods to achieve even higher efficacy?
It's an open question. Yeah, people are trying to do that, answer those questions now. Definitely.
Okay. So since okay, there's a question about can we bring patient from abroad to for treatment? I guess maybe they can find out whether there's a SANT
Yeah.
clinics in their own
Yeah, so there's
country.
a company called Magnus Medical and they have like a map with all the locations. I mean, there's been some discussions about having some out of country, locations. There's a discussion about trying to put one of these in Hawaii. so that
Hmm.
Asia can have access to it. I mean, be interested in folks' thoughts on how interested that, folks from Asian countries would be. But I think that that's, and then there's all sorts of saint-like technologies that are being developed in say China and other places that
I
I've
thought
heard
it's a
about.
patent.
Yeah,
It's
there's patents.
intellectually, yeah, patent
Yeah, there's
property.
patents in place, but yeah, it's kind of a tricky situation.
I see.
Yeah, so there's a lot of interest in this. The paper's been cited like 600 plus times already in the last couple of years, and so it's definitely on people's minds. So
Okay. And people ask, how can we participate or receive the treatment if they're not in your medical system? Um,
well, it's all those things that I was saying. I mean, if it's we've had medical tourism from other countries here. I'm speaking with some Middle Eastern, like a health minister of one of the Middle Eastern countries soon to talk about setting stuff up there. I mean, so there's definitely international interest in doing this. So
okay. Are there any follow-up after send treatment? I guess you answered that. Yeah. Okay.
yeah, just more treatment. Yeah, that's kind of the idea. So.
Okay. Are there any current same research studies accepting participants, adults or children?
Yeah, so there are Magnus Medical has a number of trials. We wrapped a lot of our trials up, but if folks want to reach out to them, they can. And like I said, I mean, Medicare is now paying for this in totality, so you can get this for free if you have Medicare or Blue Cross Blue Shield.
Okay. Let me see. Somebody is curious about what algorithms used to find out TMS target and brain is machine learning part of it.
Yeah, so machine learning actually is how we develop the personalized target. So it's called hierarchical clustering.
Okay. Okay. I think we pretty much cover. There's many questions, but it's related to the other disorders. Yeah, bipolar, ADHD. Okay.
Yeah, we're bipolar is happening, and some of the other ones are happening. So we're definitely trying to push other diagnoses. So
Okay. There's another question. Actually, it's my question. Um, since the SIM has a higher efficacy, why can people directly use a scent instead of going through the conventional RTMS? And then
the
you try
it's
that. Yeah.
yeah. So, when I first started working on this, it was like, oh, the important part is to make a good treatment. And then we did that. And then the next step was, oh, well, you need to get it FDA cleared. And then we did that. And I said, okay, well, like we're done now and everything's going to be great. And then you realize that's not true. And then you need to get reimbursement. And so you need to get these codes. And then that takes time. And then you need to get insurance companies to agree to this. So it's like, really what the game is getting the insurance companies to pay for it, right? And
Right.
and
Hmm.
as soon as and so Medicare and Blue Cross Blue Shield can do that, and so then you don't have to do normal TMS, right? With everything else, you have to do normal TMS, and so it's about convincing the insurance companies. It's an insurance company game at the end of the day. That's all that really matters.
For even for the patient receiving RTMS initially with a positive result, can they switch to scent?
If their plan pays for it, absolutely.
Okay. Okay.
Yeah, so I mean, if you got if you had TMS and you had Medicare last year and it worked for you or it didn't work for you, if you want to get TMS, if you want to get Saint this year, you can just do that.
Okay. Does people need medication after scent? I guess I
We
guess not.
tell people, we tell people not to kind of acutely come off of their meds, but
Mhm.
eventually, over a longer period of time, we can taper people off. So
Okay. All right. I think we pretty much cover all the questions or relevant questions. Okay.
cool.
Cool. Cool. Thank you, Dr. Williams, for
Yeah,
sharing your knowledge with us today. And
absolutely.
I know that you're gonna have an event this evening, panel discussion for film screening, and I wish you a successful event this
Oh,
evening.
thank you so much. Yeah, thank you. Yeah, and anybody that's in in kind of the Bay Area, there's a free screening of a movie with some of our psychedelic work that'll be playing tonight at Stanford. So happy to share that info with folks. So
Yeah,
okay,
yeah,
great. Yeah, and
right.
Alan, if you cut that
Yeah, so
that
we will cut off the patient, and we will send the video to you for approval before we publish it.
perfect. Okay,
Yeah.
great. All right, cool. Thank you, sir. Good to see you.
Yeah. Thank you.
Bye.
And then thank you to everyone for joining our webinar, and we hope to see you soon again in the next webinar. And this webinar is being recorded. The recordings will be available on the Alan Hu Foundation website and Alan Hu Foundation YouTube channel in about a few weeks. And please subscribe to Alan Hu Foundation YouTube channel. And also please take a moment to fill out a short survey. Your input is critical for us to improve the program. I will leave the donation QR code for a few more minutes. And thank you for donating to support our programs. And I'm going to close the webinar. And thank you, Dr. Williams.
Thank you, sir. Good to see
Yeah.
you.
Take
Bye.
care. And thanks, everyone. And bye. And stay well.